discussing about what are the indications for stress test, high risk feature in stress test where the revascularization is definitely required, positive predictive value and negative predictive value because there are fallacies of this test, and what are the guidelines based on the evidences it suggests about the revascularization. Briefly, we'll discuss about the ischemia trial and example from our cases also. So the stress test, the principle is obviously that with the stress, either pharmacological or physical, we increase the heart rate, we increase the vascular demand of the myocardium, and by virtue of that, we identify which area of the myocardium is not getting normal blood supply, and based on that, we would be doing the revascularization if the adequate ischemia is there. The stress ECG is easily available widely, and it's been the oldest test for finding out the coronary artery disease. So we know that this, if we have to have patients who have got chronic coronary syndrome or acute coronary syndrome in recent past, or the patient who has had previous revascularization, the stress test is done, but it has got low sensitivity and specificity, which we'll discuss later on. If you see the prognostic indicator on electrocardiographic stress testing, there are, the functional capacity is looked at, ST segment depression, the exercise-induced hypotension, and even the drop in alone, and stress echocardiography has prognostic values also. There is increasing severity of regional wall motion abnormality after peak stress corresponds to a higher clinical event rates. So if you look at the MPI, that is same principle is used, but we use nuclear medicine, and there is a PET scanning of that aspect is done. So definitely it involves some kind of radiation as well. But look at this systemic review that reported sensitivity and specificity of SPECT for diagnosis of coronary artery disease of 82% and the specificity of 76%. So, but the 91 and 89% for the PET was there. So definitely this is considered to be the best modality of a stress test. But obviously the limitation is that radiation exposure, higher cost, and limited availability is there. So stress cardiac MR is also done, and it is also using the same principle. The information and the images are much better, so the false positivity rates are significantly lesser. So if you look at the different stress tests and their clinical likelihood of getting patients rule in of the coronary artery disease versus rule out coronary artery disease, they are not really the highest of the order. But if you look at the different tests, at best the stress test would be to the tune of 85 to 90% of sensitivity and almost 80% of specificity. So there are different comparison, and now we test these accuracy of these tests by the FFR, which is an invasive test, but definitely FFR is as of now considered to be the best test for decision making. So when to revascularize, obviously if the patient is having significant symptoms, but if the patient has got significant more than 20% of myocardium at risk, we say that it is strongly positive or ischemia burden is high, and there we should be doing. So obviously, if you look at this angina symptom algorithm there, if there is a documented ischemia and on the stress test you see the multiple segments of ischemia is there, then definitely they would be needing revascularization. And of course, the FFR, which is, now we have got non-invasive CT FFR also, there also we can do this test and find out whether it is significant, and if it is less than 0.8, then they would need revascularization. Obviously, we should be looking at not only the proven ischemia, but also the symptoms of the patients, and then go for revascularization. So indication for revascularization, patient with stable angina, which is, or silent ischemia, which was controversial, and that is why the appropriateness of treatment came. And we need to demonstrate that this ischemia is significant. And if you look at that if the patient has got, more than 50% left main disease, proximal LAD disease, so these all fall the class 1 recommendation for the revascularization. Again, the FFR is in the guidelines embedded, but if you look at the imaging guided revascularization, that is still at best class 2B indication. So The FFR is invasive arm, but the stress test should be done in, non-invasive lab with various modality, whatever the availability and expertise is there. And this algorithm also shows that most of the time, if the patient has significant ischemia, we need to revascularize. The revascularization can be done either by surgical, bypass surgery, or the PCI. And there are various features. The higher the risk, higher the syntax score, multivessel disease, proximal LAD, left main disease. These are the situations where the revascularization by the bypass surgery is much better compared to the PCI. So of late, with the proven efficacy and of the drug-loading stents and the good long-term outcome, both the things are considered to be equally good. But there are certain indications, as the guideline shows, that we need to do surgical revascularization in diabetic patient, left main with triple vessel disease. But remember here, without proximal LAD stenosis, the guideline says that doing a bypass surgery is class 2B indication. So we should, not do the CABG in patients who have got type, proximal LAD and left main is not involved. So ischemia trial also did show that, most of the time, unless the patient has acute coronary syndrome, we can manage them with the, medical management. So quality of life definitely becomes better. So I'll show one example. This is a 64-year-old male who had symptoms, but he was having, the stress test did show that he had ST depression on exercise. He got the CT coronary angiogram, and you can see here that the patient had the proximal ostial LAD significant disease. We did the angiogram. The right was absolutely normal, and you can see the ostial LAD was significantly diseased. We did an OCT imaging, found out that the ostial LAD had got significant narrowing, and then it was revascularized. So you can see after using the cutting balloon, the patient angioplasty with ostial LAD extending into the left main, the stenting was done. And again, it was reconfirmed by OCT imaging, and he had perfect outcome. So to conclude, I would say, friends, ladies and gentlemen, that stress test, if it is showing significant ischemia and the patient's symptom is also positive, if the Jeopardy score is more than 20% of the myocardium is involved, then they definitely need revascularization. In between, we should be guided by the symptom of the patient and the ischemia burden. Thank you very much for your kind attention.